If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. Y'all, welcome back to the Driven Athlete Podcast. It's your man, Dr. Kyle, and we got a really cool special guest with us, Dr. Phil Saville. He's a spine surgeon, orthopedic surgeon, and coming from a super busy schedule, he's been able to come hang out with us and share more about what he does and what we're, the type of things he's into. But introduce people like where you're at, what's your practice, and what y'all do.
Well, thanks for having me, Kyle. Good to get it done. We've been talking about this for a while.
Yeah, it's been like, honestly, it's been like a little over a year.
Yeah, it's been a while.
It's been like 18 months.
Yeah, well, that's my fault.
No. Me
sorry.
too.
Okay. So yeah, my office is in Palm Beach Gardens. We specialize in kind of minimally invasive spine surgery, so less damage to the healthy tissues to fix the problem. And in particular, I'm interested in motion preservation, so disc replacements, non-fusion options for patients, which is certainly gaining popularity. People recover faster, get back to their active lifestyles, and have a lot less side effects down the line. I trained in England initially for med school, a place called Leicester, and then came over here, did my residency at University of Pennsylvania, my fellowship in HSS in New York, and then came down to Florida around 2018 and opened up my own office about 3 years ago now.
Cool. Yeah, that's because we had met up in Juneau at Dr. Danielle at one of his first there.
Yeah,
they had like an open house thing.
Exactly right. Yeah.
And that was like right after you opened. Is that right?
Yeah, that was I was busy pounding pavements then, just trying to meet everyone in the area because it was a new area. I'd moved up from Boca Raton and had to meet all the people up in the area. But yeah, that was then.
So all right. I knew you were from London originally, right? You can tell by the accent if you guys can't tell. But so you went to Leicester Medical School. What brought you over to US to go to University of Pennsylvania?
It was, the NHS is a socialist system, and there were some issues with that. But the main issue I noticed was the case volumes were just decreasing. It's not a very efficient system, so surgeons weren't doing a lot of cases, and the guys that were a few years ahead of me in training didn't seem to be progressing and really achieving what the guys 5 or 10 years before them were able to achieve. So it was kind of a decision of, do I stay here and potentially extrapolate that trend and just not be very good, or do I go somewhere else and try and become good at what I do? And that was what really drove the decision making.
Interesting. Did you always know you want to go to orthopedics or spine?
Not really. It all kind of just happened. In England, the rugby boys all went into orthopedics. I played rugby, so I went into orthopedics. And then when I was doing my orthopedic rotations, I had an Irish surgeon, Dennis Calthorpe, who did spine, and we just got on, and he just took me under his wing, and that was it. I was like, I'll do spine.
And was that during one of your rotations at medical school?
It was actually after medical school. So I was doing some residency equivalent in the UK and worked for Dennis, and I was on his service for like 6 months, and we had a really good time. It made sense, and I just enjoyed the surgeries, and it just kind of led from there, really.
So then you started investigating residency programs in the US.
Yeah, I looked at a couple of options, and Canada and the US were kind of top of the list, and ultimately the US was probably the better fit. It's easier, surprisingly actually, to match over here as a foreign grad than in Canada. Canada's really closed shop. And then came over here, interviewed. I was lucky enough to get into a good program in UPenn, and it all just kind of led on to each other, really.
And was that, UPenn, it's a great institution.
Yeah, I was really lucky. I just got on well with the team there, and they made a spot for me, and it went from there.
That's cool. And that first residency, was it an orthopedic residency, orthopedic surgery residency, and then you do fellowship for spine?
Exactly. So we do, in orthopedics, you do spine as part of your general rotations, and you kind of do, when you're done, you're capable of doing spine surgery and general ortho surgery, like joint replacements, fracture care. But to get kind of the next level of training, you then go on to like a fellowship for a year. And that was done in New York at HSS, which is obviously quite a well-known place down here. And that was kind of where we learned like the next level of how to treat spine care.
Yeah. And is that specifically like cervical, lumbar, or like the whole spine?
top to bottom.
Got it. And then right now for your guys' cases, like, do you see equally distributed like neck and back?
Yeah, probably 50-50, pretty close actually. Yeah. I mean, there's a little bit in the thoracic spine, um, but for various reasons, you just get less pathology there.
Yeah.
Probably less than 5% is
Right.
in the thoracic spine. The vast majority is in the neck or the lumbar spine. Um, the books will say it's 60-40 lumbar favored, but I think generally it's more like 50-50 now.
Yeah, pretty close. Like, um, that's interesting. And I remember you had referred somebody over. He was a young guy, mid-30s, who had like thoracic. I tell this story
Hmm.
on other podcasts and stuff, or just and also mentorship stuff with some of the fellows that we train. But he was like a young dude, early 30s, and he had thoracic region pain.
Hmm.
And it was weird. It was just like, this is interesting. It was kind of puzzling. And it was referring like a dermatomal pattern like
Yeah, yeah.
across his rib cage. And I was like, all right, if it's musculoskeletal, I'm thinking rib pathology, core stability, thoracic spine mobility is
Hmm.
important. Look at the TLJ, like
Yeah.
thoracolumbar junction mobility. But anyway, he's like, I'm gonna get an MRI just to, rule out some stuff. And his symptoms were like, it hurts when he was sleeping. He didn't feel good in general, like general
Yeah,
lethargy.
I remember who you're talking about now. Yeah.
And then spoke on the phone, and he was going to MRI. I was like, hit me back, check out the imaging, and then hit me back and we'll
Yeah.
schedule. But anyway, I didn't hear from him, and I reached out. I was like, have you heard from that patient? And you're like, yeah, he actually had a tumor
Yeah. No, he did. Yeah.
in his T-spine.
He had an intradural tumor, I think, that was um, just, it's unexpected, certainly in a young person.
Right.
He actually went up to New York, I think, to some of the guys I trained with to get it fixed. We sent him up to Sloan Kettering.
Have you heard from him since?
I haven't actually, no.
He was in his early 30s. Somebody coming in with like mid thoracic region pain, hurts with breathing, right? Across like the rib cage.
Yeah.
But beside, like, what other pathology? What would be the protocol for that? It's like, hey, immediately just imaging just to rule things out.
Yeah, so I mean, it depends on history and duration. So, I mean, the vast majority of 30-year-olds with thoracic level pain is going to be something benign, nothing to worry about, right?
Right.
So it's going to be a muscle sprain. They've been playing tennis, golf, something's happened. But if it's not getting better, if it's interfering with sleep, if it's been going on for a while, then that's more of a red flag, and that's something more that would send us towards workup towards, is there something more going on? If the pain's kind of coming across in like a dermatomal distribution, so it kind of starts in the middle of the back and comes along in a rib in a line to the middle, well, that sounds a lot more like nerve pain. So you maybe start thinking about, is this a disc herniation pushing on a thoracic nerve? Can even be something unusual like a shingles flare. I've seen young patients with that. I had one last week who had some pain radiating down his arm, in his shoulder. Everyone thought it was a disc herniation, and the disc MRI was negative that he came with. When I asked him to take his shirt off to actually examine him, he had a classic shingles rash all down.
Interesting.
And so we sent him to his primary care doctor actually to get antiviral treatment, and it all got better.
Interesting. So
yeah.
before that, nobody does like take your shirt off?
No. I mean, he kind of came to me slightly unusual. He's a friend of a friend. I saw him out when we were out having drinks one night, and his friend was like, "Hey, go see Phil. He'll be able to help you out, figure out what's going on." So he came to see me the next day and had his MRI already, and it was really unimpressive. And I just, by chance asked him to take his shirt off, which you don't often do, to be fair. And he just had this clear dermatomal rash, and it was shingles, 100%. And he got better just with antivirals and a bit of time.
Interesting. Yeah. Yeah, that's super interesting. And then so you did your fellowship with HSS. Were you employed with them at all? Like, did you work with them while, like, right after fellowship, or did you immediately come down to Boca?
No, I came down here immediately. My wife is from Brazil and wanted to be down in Florida, and so
Yeah, away from New York.
yeah. I mean, when we met, she was moving to Miami, but put that on hold because of me. And so we made the deal that if we were still together at the end of training, we're coming down to Florida, and so I had to keep that deal. So we came down here. I joined a group down in Boca, and it was a good experience. But ultimately, I wanted to do something a little bit different and be my own boss, and that's what led that to change in about 3 years ago now.
What things different?
I tend to run a lower volume practice, so I mean, I guess the term down here is concierge, but it's kind of more lower volume, out of network, and able to spend a little bit longer with the patients. Where I was before was a good practice, but it was a volume play. Basically, you had to see new patients every 15 minutes, and it's hard to examine someone, take their shirt off, and talk to them about surgery in 15 minutes, and then do your documentation.
Yeah.
And if people have questions, if they've got a little bit of understanding, they're going to have a lot of questions before you operate on them, and it becomes challenging to do that. And so the goal was to run something a little bit more like yourself, where you're able to focus more on individual, what's actually going on with them, what the right thing to do for them is, rather than just this is what we do, this is what we do, this is what we do.
Give me what give listeners an idea of like what if a new patient came to see you, right? Hey, I'm Dr. Saville. Nice to meet you. Right, it's day one. What does that first day usually look like?
I mean, it depends really. I mean, ideally they've had an MRI already, so it can be a more fruitful discussion. If they come in with symptoms and MRI, then yeah, it's going to be like 25-30 minutes. We'll go through exam, looking at the imaging, talking about what the options are. Depending on what they've done already, we may go for some injections if they've kind of fresh and have had nothing done. If they've done a load of injections already, this has been going on for months, and they're kind of getting to the point now where they hey, like, let's just get this fixed, then we start talking about surgery. And it really depends where in that spectrum these people come in. Some people have come in having dealt with this for years and done injections for years, and the injections stopped working. Other people that they tweaked their back 2 weeks ago, and that's clearly not a surgical talk. That's more of a, let's try something to settle this down, maybe get you over to see Kyle, do some therapy, and then we go from there.
Yeah, yeah, gotcha. And then exam wise, what would people expect? Like when you do an exam on somebody,
Mhm.
like range of motion,
Yeah, so it's
flexibility.
range of motion, the neck, the lumbar spine. Then we look at painful motions. Does it hurt when you're rotating, when you're looking up, looking down? Then we start looking at the individual muscles which are supplied by the nerves in the area. So in the neck, we're looking at the arms, looking at the shoulders, the biceps, the triceps, the hands, the wrists, looking to make sure there's no weakness associated with nerve compression.
Right.
Check the sensation. Again, each patch of skin is supplied by individual nerve roots from the neck or the low back, and so we test each of those. Check your reflexes. In the neck, we'll often check balance and coordination. A lot of people are surprised to know that compression on the spinal cord may be painless, but can affect your balance and coordination. So that's something we always like to check, especially on the neck patients.
Right. Like
Um,
cervical myelopathy you're talking about?
exactly, myelopathy is what we're looking for in that case. And that really, again, it's kind of tailored depending on what's going on with them. Uh, yeah, someone has just got a little bit of back pain when they're golfing, and it's on the kind of the follow through, then we're probably not going to maybe do quite so much than on someone who's come in with more neurologic symptoms.
Gotcha. And if something come in neurological symptoms, where you're describing like testing myotomes and dermatomes, like weakness in the hands and arms, um, leaning more towards, and they've had pain for a long time. Then you're talking surgical considerations,
Mhm.
and that you said you're leaning more towards like, as an example, if needed, disc replacements over instead of fusions.
Yeah, so disc replacements are something that have really become a lot more popular over the last 5 to 10 years. You look at initially around 20 years ago when they started being put in, they were being put into very young patients who had no degeneration in their neck or their low back, and they were for soft disc herniations, which is kind of what we describe as an acute disc herniation without any degenerative changes. Certainly over the last 5 years, that has kind of changed a lot, and now really quite degenerative necks that we would not have put a disc replacement in 10 years ago are now becoming candidates for disc replacements. The advantages of a disc replacement over a fusion are pretty well known and well studied now. You have a lot less pain. You maintain range of motion. You have less revision surgeries at the level of surgery and at the adjacent levels. So if you have a fusion in the neck or the low back, you end up transferring motion at the levels above and below. So they try to maintain your range of motion, so they work twice as hard, which means those discs then wear out. And so you end up chasing yourselves up the neck or the low back with further surgeries. And I think most listeners will have known someone who had a surgery and had another surgery in their back, and it's kind of not a great story, right? Everyone always is worried about that. Whereas with disc replacements, we see that that's not the case. You have far lower rates of adjacent segment wear out and less surgeries at the index level as well.
Interesting. With disc injury,
Mhm.
right? What would cause like an acute, non-degenerative type of soft disc injury, like you said?
It can be anything. I mean, it's nice when there's a clear precipitating event. So you lean forwards to pick up something heavy and you feel a pop in your back. That story is nice and everyone kind of agrees and understands that's when it happened. But often that doesn't happen. You can have like just a disc that's been injured years ago. It's hanging on by a thread. And then one day it just goes. It can be when you sneeze, when you roll over in bed, and it can be something so innocuous that starts it. Um, the way to think about a disc is it's really made up of two layers. You have the outer layer, which is like a thick car tire, it's rubbery, and the inner layer is kind of like a gooey crab meat type material. And so it works well together as like a shock absorber. And when you have a disc herniation, what happens is that outer layer gets a hole in it. And so the crab meat can squeeze out and pushes on the nerves. And it really can be like you hurt your back playing football or at the gym 10 years ago, and it's just hanging on. And one day that thread just goes, and then you get some disc squeeze out.
Interesting. What evidence or like what do you? Because people will ask me like, do discs heal? What have you found in the research with that?
So it depends what you mean by heal. So if you injure a disc, it will break down. Unfortunately, the disc doesn't have any real blood supply. So it doesn't have a tremendous healing potential. And once you injure a disc, it will go down a degenerative cascade. But that may or may not be painful. And a lot of people will come in and they will have very degenerative backs or necks and they have no symptoms. And that's just because some people go down this cascade where it's not painful, and other people go down this cascade where they have a lot of back pain. And there's some genetic component to that. And I don't think we entirely know that yet. But it's certainly some people have no pain, some people have a lot of pain. If you're getting a lot of low back pain, and we look at the MRI and you've got one or two of these worn out discs at the bottom of the back, then and you've tried all the other things like the therapy to strengthen the core, the injections, and then all these things aren't working, then you may be a candidate for a disc replacement where we scrape out the disc and we put a new one in. And in my experience, patients have been very, very happy with those and do very well, return to activity. I mean, we have several videos on our website now of young patients who couldn't play with their kids, couldn't lean over to pick them up, and now they're back playing sports with their kids, which is what they want to do.
It's amazing. Yeah.
Yeah, it's been really changing for, I think, spine surgery, the arthroplasties.
And that's still what's the with the invasive nature, like with it's arthroscopic.
No, so
Is
so disc replacements in the lumbar spine we do with an anterior incision.
okay, interesting.
So we make either a transversal or vertical incision depending on the level, and we go between the abdominal muscle. So we're not cutting muscle; we're going through the tendon in between, which we can stitch and heals well. And then from the front, we have an approach surgeon, a vascular surgeon typically, who moves the blood vessels and the peritoneum, the bowels out the way. So we're looking straight at the spine. And we just scrape out the disc, open up the nerves if there's any compression on the nerves, and then put the new disc in. It takes about an hour, maybe an hour and a half if you're taking a little bit longer.
For a single level. Would
Mhm.
y'all do multiple levels at once?
Yeah, yeah. I would do two. Two is typically at once, one or two. Three can be pushing it. Three's a lot, but usually it's one or two level pathology.
So a 2 level would be like 2 levels at the same time, hour and a half surgery.
Hour and a half to 2 hours, yeah.
Interesting. So there's two surgeons in there, the same, like you and then a vascular surgeon.
Mhm. Correct, yeah.
He moves everything out of the way.
Yeah, so it's interesting. It depends where you train. In Europe, a lot of the spine surgeons will do their own approaches. in the US for a mainly medical legal reasons. There's an approach surgeon there. I think on balance it makes sense because the real risk is if you injure one of the blood vessels when you're exposing the spine, and to have the specialist to fix them there, that just makes sense.
Yeah, for sure. I mean, the descending aorta, where does it split into
So
the common iliac artery? Is that correct?
yeah, so it's variable. I'll tell you that at L5S1 it's definitely not split there. So you've got a wide open window to the bottom level. L4-5 is usually around the level of the bifurcation. It actually tends to be the vein that's more of an issue because it's less robust, so it doesn't take
It's
being moved as
flimsier.
well. Yeah, it's flimsy.
Yeah, yeah.
So 4-5 is technically the harder level to get, and so it's essential to have a good approach surgeon, which we're blessed with several in the area. And then above that, L3-4 is actually easier again because you're dealing without the bifurcation there. So 4-5 is the hard level.
Interesting. If it does, if an accident happens like that,
Mhm.
and the vascular surgeon's there to repair,
Mhm.
is it just a quick stitch? Like, how's that work?
Yeah, I mean, typically, yeah. If we're doing these regularly with experienced approach surgeons, it's usually like a small branch of the vessel pulls off,
Oh, I see.
and so
Yeah,
it's just a small stitch and it's an easy fix.
but not the trunk.
Yeah, basically,
And I
you're
imagine it's
moving a big
super,
tear.
and I'm sure it's super uncommon.
Yeah, very very uncommon. I mean, it happens a couple of times a year. It's not like it's every week with
Yeah,
vessel injuries. That would not be.
but that's really, I mean, that makes a lot of sense. That's also, I'd imagine, very makes people feel more secure
Yeah,
having two surgeons on hand right there doing it.
I think so, and I think it just makes sense. It makes me feel a lot more comfortable, yeah,
Yeah,
having the specialist there to get it all ready for me, and then I can just focus on getting the disc in right,
yeah,
and he just focuses on the blood vessels. So it just makes sense.
yeah. That's good. Do the best job possible.
Yeah.
So patients, you don't go through the abdominal muscle tissue. You go through the tendon that heals up quick with a stitch, and then you like physical therapy after that. Like, what do y'all recommend?
So for the first week, I ask them to wear a back brace just when they're up walking around, just because the bone grows into the implant, so it becomes part of them, and that takes a few weeks. You can't really speed that up.
Yeah.
And then they're just walking for the next 6 weeks.
Okay.
Once they get out to 6 weeks, we start to use the elliptical, the stationary bike. Then once you get out to 3 months, you can go back to full activity at the gym. Now we'll start some gentle PT around 6 weeks.
Got it.
Okay. We don't want to crank on it. You don't want to dislodge the implants because then you're going to have to go back in and redo it. So you just got to wait and be patient while the bone grows into the titanium, which they spray the ends with, mimics bone. So the bone grows into it. It looks like bone to bone, and so it makes this solid bond to it.
That's really cool.
Yeah, it's cool. It's and in the neck, similar. It's an anterior incision in the neck. Usually hide it in one of these creases that most of us have. And we just go between the muscles here, so we're not cutting any muscle again. And the same thing. That's done usually just by me. There's no approach surgeon up there. Um, the vessels aren't such an issue there.
That's good. And the trachea also
Yeah, so you just move
easy
that
to
out of
move
the
out of the
way.
way.
Yeah, it all moves very easily out the way. I mean, the issues up in the neck. Some people will have a little bit of a sore throat for a few days afterwards, um, but it usually settles pretty quick. And we put them in a collar again for a week. They take it off to sleep, just when they're out walking around, really. And similar, no lifting anything heavier than a gallon of milk for the first 6 weeks. Then 6 weeks, you start doing gentle therapy, gentle activity with the elliptical, the stationary bike, and then at 3 months, you're back golfing,
Like
tennis.
full go.
Yeah.
What do y'all do multiple levels at this neck the same way as the lumbar spine pretty commonly?
Yeah. So frequently, we're doing like 3 levels at the same time now in the neck is not uncommon.
Interesting. How time frame? How long is the surgery for that?
About an hour level, typically what we recommend.
Oh, okay. Gotcha.
Yeah, so 3 hours for 3 levels, or 2 hours for 2 levels.
And what are the most common levels you guys usually do? See,
5, 6. Yeah, 4 to 7 is probably the most common, and I think 5, 6, and 6, 7 are the most common too.
Interesting. Yeah, that makes sense from what we've gathered.
Yeah, it's to do with the angulation and the shear. So the 5, 6, and 6, 7 are at the most angle, so they see more shear force. So those discs tend to wear out faster. Discs don't do very well under shear, That's similarly why the 5-1 wears out the fastest in the low back. It's the most shear.
Yeah. You had mentioned to me in the past about like a multifidus muscle stimulator
Mhm.
post-op or just for back pain.
Yeah, so that's the Reactivate device. It's interesting. It's did very well in clinical trials. So it had around like a 70% improvement in people with this chronic low back pain without any real surgical target. I think in practice, most people feel it's not quite as successful as that. It's probably more like 50-50. I think it's useful in the older patients who have had a lot of muscle wasting.
Mm.
And I've implanted in a few patients who have had scoliosis and with just back pain, no nerve symptoms, no neurologic, just pure back pain. And where the fix would be a 7-8 level fusion, which is a pretty big surgery and not something that they were either medically able to undertake or had the desire to undertake. And so we've implanted in those patients, and I think we've had good success with those. Certainly their back pain's improved and they've avoided a much larger surgery. There's some thinking that the multifidus muscle, which stabilizes the lumbar spine, when you have a painful stimuli, it turns off. It's a reflex muscle. It's not one that you can just do a bicep curl to strengthen it. It's one that you subconsciously contract, and it stabilizes the spine by giving you a solid base. So now if you've got a bad disc, you've got a bad joint in the lumbar spine, if you were to compress, it would hurt. So your body doesn't do that. And over time, when that insult's gone away, so it's no longer painful, that muscle doesn't turn back on. And so you have this instability in the back, which causes some pain. And so this device stimulates that muscle for 30 minutes twice a day. And there's some neuroelasticity where you re-innovate that muscle and it starts to get back under the reflex control from the spine. And I say it's certainly interesting. I don't think we've got all the answers yet for it, but it certainly is another tool in the toolbox.
Right. Yeah. Yeah. Exactly. What of the disc replacements or just like a debridement discectomy?
Mhm.
I'm sure you guys do a lot of that too.
Yeah, so I do a lot of just disc herniations, decompression. So if you've got really no back pain, mainly leg pain, going down the legs when you walk or when you're standing up, then yeah, you really just want to remove the compression on the nerves, and so you do that a couple of ways. If it's a younger patient, it tends to be a disc herniation, so you just make a small incision, remove that fragment of disc, leaving the rest of the disc behind, take the pressure off the nerve, and the pain goes away. I'm sure we've had patients with that.
Mm-hmm.
Do very well. It's a finger width incision. It takes 40 minutes probably. If it's an older patient where they've got more arthritis and it's more of a stenosis type picture, well, then you have to kind of do a little bit more work. The same size incision takes a little bit longer, more like an hour and 20 minutes. And you're kind of removing some of the arthritic bone and some of the hypertrophied ligament that's compressing on the nerves. Both do very well. And you're avoiding a fusion, you're avoiding any metal being put in the back, which is great.
Would that be the ligamentum flavum? Is that the main one?
Exactly, the flavum, yeah.
Describe to people what stenotic changes mean.
So stenosis just means narrowing. I mean, I think the way to think about it is we're just like plumbers essentially. The spinal canal is a big long pipe, and the spinal cord and the spinal nerves run through it. As you get older, and the arthritis in the joints, the facet joints in the spine, and the disc starts to degenerate and bulge, it starts to narrow, and you get these kinks in the pipe, and so the nerves get pinched, and the signal, the flow doesn't go down the nerves very well. So all we do is go in there and just basically, like a rotor router guy that cleans out your toilet, we just open up the nerve.
Shave off the.
Yeah, so trim the ligament, shave some of the arthritic joint. Sometimes it's discs, because we remove some of the disc. It really depends on when you look at the MRI, sometimes it can be a cyst. You can have a cyst from one of the facet joints. And in that case, we just remove the cyst and open up the nerves.
Between discectomy and debridement decompression and anterior disc replacement, what do you find yourself doing most often?
In the lumbar spine, I think we probably still do more decompressions than disc replacements. some of that's the population down here. I mean, we have an older population. They're not all necessarily candidates for disc replacements, but disc replacement's growing. Some of it's just patient awareness. We're getting more and more patients that have been told they have to have a fusion coming in and being told, well, actually, no, you're probably a candidate for disc replacement. So I think over the next few years, that number's going to change.
You're going to continue to go in that direction.
I think so, yeah.
Interesting. What do you do for your own back? Like, how is your back?
It's surprisingly good, actually, considering I played rugby and other silly things when I was younger.
Well, rugby's fun. It's not silly, right? Like sports.
Yeah, you pay for it in the long run. Right?
Exactly.
I mean, I try to stay in shape, which is hard. I've got 2 young kids and a busy practice. I'm not doing quite as well as you at that, it seems. But that's always a goal. So,
well, for practice management? Oh, man.
No, staying in shape, I mean.
Oh, well, I'm trying,
Well, yeah. I mean,
it makes it easy, like when my clinic's a gym, I have no excuse at that point.
Yeah, maybe I need to put a gym in my office and something like that. But yeah, I mean, just trying to stay in shape, work on the core strengthening. Putting on weight, especially for men, is bad for your back, right? We tend to carry the weight out in front.
Yeah.
And that just puts extra force on the low back. Women tend to put it more lower down, more pear shaped, and that tends to be less problematic for back pain.
Yeah. But yeah, like I mentioned, well, with your wife, because we had worked with her for some stuff a little bit, and she's doing the med spa, free spa, which we'll talk about in a sec too. She was saying that you guys, do y'all work out together at Tremble or the kickboxing? Or is that only
she goes to Tremble. Sometimes we'll go to like Lifetime together and just work out there. I tend to go to there. I do a little bit of like jiu-jitsu, MMA at a local gym, just something to learn something new and challenge myself really.
Keep it fresh.
Yeah, because it gets a bit boring just kind of lifting weights every day.
Yeah. That's one of my goals. I've never really done any MMA. I did some kickboxing a little bit back a little while ago, but because I think it's just also fun, like to get some aggression out and like hit some stuff.
Yeah, I'm pretty lucky. There's a gym really near our house. I found them during COVID because everything else was shut, and he was still running it because it was kind of, I guess he had different rules because it was a smaller business and it was only one-on-one. And he was like, hey, look, if you're okay with it, I'm okay with it. And I was, yeah, let's give it a go. And I've been going, and when I get busy, that gets cut out, unfortunately, my schedule. But I need to start going back there more. But it's excellent. It's really, really challenging. He does a lot of like body weight stuff, movement stuff, so kind of bear crawls and hops and stuff like that to try and work coordination. It's just stuff you don't do as an adult anymore.
Yeah,
I think that stuff's important.
Yeah, I definitely have visions of trying to get into jiu-jitsu or Muay Thai or something.
It's humbling.
That's what I've heard.
Yeah, it's I mean, I'm pretty strong and used to doing physical stuff, and yeah, you lose every time.
To people like half your size, or like
old people that you are like, this guy should be no challenge, and they destroy you every time.
That's funny.
Yeah, so
but that's good though.
Get ready for that. Yeah, it's definitely humbling.
What so are you doing Brazilian jiu-jitsu or what?
Yeah, I think that's what they describe it as. It's
where are you right now in like your journey with your belt?
Oh, it's not. I'm not doing any belts or anything like that. It's more just kind of casual.
Gotcha.
Dropping. I mean, I'm sure we could go through gradings if we wanted, but
no,
it's more just something to do for fun.
Yeah, that's cool. But also, I mean, like and I think a little self-defense and confidence.
Yeah, I mean, I used to do karate when I was younger, and so it's kind of something I've always done and been around. Yeah, but it's definitely interesting. It's definitely something good.
So besides, all right, anything else? What would you recommend, like from the patients that you've seen and success stories for patients that have had battling back pain, and you did a decompression on them, or maybe not even doing that, but you're like, definitely need to do this to help your back. I mean, losing weight, you said.
I think losing weight. I think definitely doing some therapy or just strengthening your core, whether you do that with yoga, yourself just doing planks, or with directed therapy with someone like yourself. I mean, I think those are the simple things that you should be able to try yourself. If those aren't working, if you're still battling back pain, then I think you need to get an MRI and see someone. And whether that's injections you try next or other options, really comes down to what's going on, how bad it is. If this is, it aches once a year, if you do a little bit too much, well, yeah, then it's probably not worth doing too much,
I was
right?
gonna say, like, patients ask me, well, I'll frequently, like, at what point do we get an MRI? What do you usually recommend for that?
So if you're getting neurologic symptoms, like pain down the legs, weakness in the legs, heaviness in the legs, then yeah, definitely time for an MRI. If it's just back pain, I mean, the red flags are if you're having weight loss, if you're having night pains that wake you up, then yeah, you should get an MRI to make sure it's not cancer or something serious that we're missing. Otherwise, it just comes down to quality of life. If you're getting to the point where you can't do what you want to do, then I think it's time to think about getting an MRI.
Take some action.
Yeah, and but those goals are different for everyone. Some patients come in and they're frustrated because they can't do 2 Ironman in the same month, and other people's goals are, I want to be able to walk to the fridge, get some food, and sit down. And you've got to understand like what everyone's goals are, and that's different for everyone. And that's one of the advantages of having a slightly lower volume practice is you have the time to figure that out and talk to them,
Right.
and understand where they're trying to be
Yeah.
and where they are now, because that's really, it's unique and it's different for everyone.
Yeah. It's interesting you say, like, I'm battling some back pain.
Okay.
I ran it, like I'm saying, like, you had a patient that comes in. I'm battling back pain. I've had, or knee pain, whatever. I ran an Ironman. I'm training for another one. I have a marathon coming up next week.
Yeah. No, I mean, we get that.
Like, that's awesome. Hey, I love the enthusiasm,
Yeah. We get them. And then we get the other people that are just like, I can't stand for more than 5 minutes. My back hurts. And you've got to try and figure out, what they're looking for and what's realistic. 'Cause, if they're coming to you because they want to be able to do that second Ironman in the same month, then, the goals it's going to be hard to make that goal.
Yeah.
But if they're just coming to say, hey, look, I just can't stand anymore, then I think your runway for success is much, much clearer.
Yeah. You mentioned red flags.
Mhm.
Explain to people what that means.
So red flags are symptoms that should warn your provider that there's something more serious going on, and would prompt um, more investigation. So, classically we worry about back pain as, is this a manifestation for cancer? Because a lot of cancers do spread to the back. And so, people that complain of, just increasing pain that's just out of proportion. So, you can't function, pain that wakes you at night. And if you're having weight loss, these are all things that would make someone concerned that this is more than just simple back pain. And so we should get a good investigation. Other things that go along with it are, night sweat. So if you're okay during the day, but at night you're profusely sweating, well, that may be an indication that there's something more going on. It's either hematological or infective, and so that's something that we should bump up to the red flag for. Let's get an MRI, make sure it's not anything serious before we just say this is back pain.
Right. It's like, you're good. Let's just work on this.
Yeah.
Just to rule things out and then go from
Exactly.
there.
Yeah.
And we've had a couple mutual patient like success stories, like people have come in. One of them, I think, is coming in tomorrow to see me again, but just for continuous stuff.
Yeah.
But they're like, man, I feel amazing. Like, feel a lot better. I think they just had a decompression. This one I'm thinking in particular. The other one's very similar, actually. She actually just texted me today. I'm not going to say their names,
Okay.
but both of which had just decompression surgery.
Yeah.
And the incision's like literally half an inch long.
Yeah. So, I mean, what's different about the way we do a decompression as opposed to like the standard is I do it through a tube. So the tube's about 16 millimeters in diameter, about half an inch, the width of my finger. And so what we do is I make an incision and we put this hollow tube down to the spine, and then I work through that with a microscope with special instruments. And the more classic way is you make a bigger incision, you strip all the muscle off the bone and push it out of the way. So you're looking at the spine. So it's obviously a lot less damaging.
Yeah.
And a lot less painful. And the reason for that is most of the pathology in the spine focuses around the disc level. So if you imagine the spine's built up of vertebrae stacked up on top of each other and there's a disc in between, either through an evolution or a design flaw, depending on what your beliefs are, what tends to happen is at the level of the disc, you've got the joint, which can become arthritic and expand into the spinal canal. You've got the disc, which as it ages and degenerates will tend to bulge into the spinal canal. It's like if I go let the air on your car tire as the car sinks down, right? Well, the tire bulges into the spinal canal, so that creates problem. And the ligament of flavum, which you spoke about earlier, also um, infolds at that exact level and hypertrophies as it gets more unstable as the disc breaks down because you're trying to stabilize the segment. So all those pathologies just line up at this same level. And you'll see on the MRI, if you look at it carefully, that you'll have narrowing at the level of the disc. And then as you go up the vertebrae, it opens up and looks normal. And then it narrows again at the disc above. And you can repeat to the pathological normal level. So you just really need to go in and address that little level. You don't need to strip the whole spine. You just need to target the levels where it's narrowed and open them up.
Interesting. Uh, the and with the tube that like the incision, are you able to move a lot of the muscle out of the way, or do you have to go through the multifidus or the retrospinning group?
Yeah, so you go through the muscle. So but you're going through the body of the muscle, and the muscle fibers run longitudinally, so you end up just splitting between the fibers. So you're not really cutting the muscle, you're not removing muscle. You're certainly not detaching the muscle from the bone, which is the important part. Whereas if you go midline, the more classic way of doing it, then yeah, you have to strip the muscle off the bone, and you often actually de-innervate it. So the segmental branches, the nerves, and as you're stripping the muscle off, you're going to end up damaging those, and so the muscle becomes de-innervated.
Interesting. Yeah. Wasn't it like another interesting? The one of these patients I was describing, doing really well. They had decompression because they had pain in their leg, and then also sensory. Their sensor was affected, right? It was less sensory, and then she had a lot more pain down her leg, down her ankle, and her foot, and she was at foot weakness.
Yep.
They had decompression surgery, but the residual nerve involvement still lingers for a couple, like for several weeks, you know?
Yeah, I mean, so if you're actually getting weakness in the ankle, the foot drop, that doesn't always come back. So depending on how weak it is, we grade it out of 5. If you've still got some strength, kind of like a 3 or 4 out of 5 power, it'll probably come back. But if you start getting down to the 1s or the 0s where there's really no motion, it's kind of 50-50 if that comes back. And that's just due to the nerve's been injured and it has to regrow along the sheath of the nerve, the myelin sheath, which is what coats the nerve like an electrical cable. Unfortunately, it grows really slowly, about a millimeter a day, and by which point the muscle may no longer be receptive to the nerve once it grows back in. And in ReSpa, which you kind of touched on just now, we've actually got some interesting technology there called the M-Sculpt. And we've been using that in these patients that come in with this weakness, this foot drop, either in the legs or in the arms, when you have some arm weakness as well, where we stimulate the muscle outside the body. So we use like an electrical plate, and it gives them like 20,000 contractions in a 30-minute cycle. And we've been finding that actually that keeps the muscle ready. So when the nerve finally does grow back in, you're actually getting higher recovery rates. And it's actually pretty exciting because it can be pretty debilitating. If you can't lift your ankle up, you walk funny and you trip on it, and it's a problem. And we were actually part of the FDA study for approval for this device because it's actually used in the body sculpt in the beauty world initially. That's what it's designed for, and that's what it's sold as. But the company has started to realize as more and more orthopedic surgeons have been using it, that actually there may be something here for rehab. And so it's now got approved for post-op rehab. So for like knee replacements, hip replacements, to try and regain the muscle that's injured and damaged during those surgeries. And similarly after spine surgery for like muscle weakness as well.
Yeah.
And we've had really good results with it.
That's awesome. This patient I was saying, like, I would imagine like this expected protocol, like expectations of development. If somebody's been battling like it's severe, it's been going on for a couple months, residual like nerve referred pain, they would still have some of that after surgery. It would just take a little bit of time for that to come to dwindle.
It varies. So
yeah, what do you find with that?
Often the leg pain is significantly better immediately after surgery, arm or leg, depending on which site you're operating on. They may still have a little bit, but it's a lot better. At some point during the recovery, as the nerve heals, it becomes super sensitive. So they may have a return of the pain. usually around 2 weeks after surgery, but that's variable.
Mm,
And it's just due to the fact that as the nerve heals, it becomes super sensitive. So stimuli that should not be painful, like your clothes rubbing on it, the bed sheets, someone touching it, can generate pain. And some people will say they feel like ants on the skin, they feel fire or just pain. And that can variable. Doesn't always happen, but definitely can happen. The sensation loss tends to be slower. So it'll often be better after surgery, but that can take a few weeks or months to fully resolve. And it doesn't always fully come back. So you may have some numbness in the tip of the toes or something like that, which never
yeah,
really comes back, unfortunately.
yeah, yeah. We have another patient that has been bad. This person had a stroke
Hmm.
and also back pain,
Hmm.
and had referred like sciatica type symptoms down their leg, and foot drop because of that. But the stroke wasn't related to his foot. And we've been working this similar kind of thing with M
Mm.
sculpt and working on foot
Yeah,
strength and stuff and just reactivation. It's getting better, which is cool.
good.
And he's older, so I'm like, oh, the ceiling
Yeah,
of expectation here is a little bit lower than somebody maybe who
yeah, definitely, definitely.
would be in their 20s. But anyway, and residual like toe and heel, like foot numbness.
Hmm.
Um, but anyway, previous to that, he on the other leg had a similar thing going on, and he said after 2 years, all of a sudden turned a corner and his sensation returned. It's 24 months post.
Yeah, I
There's
mean,
just the beginning of this pain to be developing.
unusual, but can
Yeah.
happen.
It's super. Anyway, I was like,
Yeah,
because it's interesting. I would agree with you. Like, it seems like most times it's like there's a lower ceiling at this point, depending on how involved it is. And then randomly you get some people that's like,
yeah.
after like an 18 to 24-month period, for some reason, it just came back.
I mean, there's a lot we still don't know. There's definitely some
I think it's just super
plasticity in
interesting.
the brain that there's some like ability to rewire. Some people have more than others. I mean, there's definitely some degree of the longer the compression on the nerve before surgery. We arbitrarily have this 1 year cutoff
Hmm.
that you do better after less than a year or worse after a year, but it's definitely a continuation. So 6 months is probably worse than 3 months, and 18 months is worse than 12 months.
Yeah, yeah.
But there's also this individual variation that some people are just able to heal nerve tissue better than others, and
It's
yeah,
interesting.
it really it's unpredictable, and it's always hard to explain to some patients that look, you're just in the slower recovery group. I think we're going to get there, but it's going to take a little longer.
Yeah.
And yeah, most people understand that, and they'll say, oh, I heal slow anyway after other surgeries, and usually they kind of have this like history of just slow healing.
Yeah. So let's talk about respa.
Hmm.
So you guys in your office, where you do your consults and your clinical,
Hmm.
you also have like a med spa type
Yeah,
facility.
so it's more like a functional med spa. It's my wife's passion project, really. I think she after her pregnancy, in particular, I think we had twins, and I think it hit her pretty hard. And so she was looking at kind of ways to get back to her activity level, and that was kind of when we discovered this M Sculpt and the M Seller, these kind of um, machines that use radio frequency and electromagnetic field to stimulate muscle growth and strengthening, and I mean, there's pretty impressive results when you pair the M Sculpt on the abs and the M Seller for the pelvic floor in terms of um, like uh, young mothers who are like 1 or 2 years postpartum in terms of recovery of urinary function, strength, and back pain. Regeneration is pretty impressive, and even in the elderly patients, in some of the studies that got the machine approved for the rehab, they looked at 65-year-olds and stimulated the core with the M Sculpt on the abs and the low back and the pelvic floor, and they showed improvements in agility, so time to get up and go, how long it takes them to stand up and walk a distance and sit down again. Back pain was significantly improved, and more interestingly was their ability to stand on one leg, how long they could do a single leg stance improved.
Mm,
And that's actually the most predictable about your longevity. So once you get over the age of 65, the longer you can stand on one leg without falling over and losing balance indicates how long you're going to live. And it's actually the best predictor of that, which is very little known fact.
interesting. Yeah.
Yeah.
And I would imagine like kind of a correlation with that would be the In order to be able to balance on one leg, there's like a lot that needs to kind of be maintained in order to do that.
Oh yeah, I mean it's a
like,
lot, right? So
yeah,
it's just, I think it's a marker for your general just function.
overall functionality
Yeah.
and fitness.
Yeah.
Totally. Well, that's cool. Well, I appreciate you coming in. Where can people find you? Like, how can people reach out if they're battling back issues, neck pain, nerve related pain, or like, I think I need to get a consult or check it out? How do they reach you?
Yeah, so I mean, you can just email info@Seville Spine, or look on the website at sevillespine.com, and there's lots of like chatbot and forms to just put your details in, and one of the team will call you same day, next day, and we'll see what we can do to help.
Gotcha. Well, thanks for coming in.
Kyle, thanks for having me. I'm glad we did it.
Yeah, I'm glad we finally got it on the books, and we'll definitely be collaborating and stuff and patients in the future. And if you have any questions, don't hesitate to reach out. We're always open to questions, comments, concerns, conflicting opinions. And if you're already battling any issues that you feel like we could help, feel free to reach out. The best way to reach us is probably our phone number at 561-899-8725, or like our website, like Dr. Phil was saying for his too. And then we'll catch y'all next time.